And welcome to the Dr. Bob Show. We're going to be spending most of this show talking about you. Are you performing as well as you used to? Do you think as well as you used to? Sometimes you forget things. That could be normal. Could be the beginning of abnormal. Are you socially changing? You're becoming more irritable, a little bit more sloppy. Are you doing worse balancing your checkbook, coordinating numbers? We'll be spending most of this show talking about the changes that could be normal or could be abnormal. My guest is Dr. Monica Crane. Dr. Crane is one of the most delightful and educated young physicians that I know, and she has dedicated her life to dementias and what's going on in the world of dementia, the things that are changing your and mine attitude and activity. You're going to enjoy this show. She'll be answering our questions. I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes. Later on, we'll be talking about postural hypotension. When you stand up, you get dizzy and faint and maybe fall down. And we'll be talking about a heart valve. I haven't decided if we're going to talk about the aortic valve or the mitral valve. Stay tuned to find out which one we're going to talk about. A lot of information for you. I wonder why I couldn't think about that. Maybe it's dementia. You'll want to stay tuned. We're talking with Dr. Monica Crane, Clinical Medical Director of the Genesis Neuroscience Clinic in Knoxville, Tennessee. Monica, welcome to the Dr. Bob Show.
Thank you, Dr. Overholt, for having me back.
It's so always nice to have you as a guest. You really do such a wonderful job. Let's talk about dementia, just what does dementia mean?
So dementia is not a diagnosis. It's a cluster of symptoms. Think of it like this. The word cancer, you can't go to your doctor and say, you just have cancer. They go and tell you a subtype. So under the umbrella of the dementia family are many diagnoses, and Alzheimer's, of course, is the most common subtype.
So dementia is under an umbrella, lots of different ones. We know Alzheimer's. More and more people seem to be getting Alzheimer's. What's going on in the brain with Alzheimer's very quickly?
So with Alzheimer's, we see damage in areas like the temporal lobe, the memory areas, and the areas towards the back of the brain that affect our visual memory. And we find on the slide, you can see plaques and tangles. So we know a lot about the pathology. We're still trying to figure out the cause, but we know it's the most common and it's actually quite treatable.
So when you treat it, it's a progressive neurodegenerative problem. Well, how is the treatment for Alzheimer's?
The treatment for Alzheimer's is a combination of medicines as well as non-drug interventions. So there are a lot of things that we can do. There are experimental medications as well. So it's a big process of multiple things to help fight a big disease.
So in this illness, this dementia umbrella, where we've got Alzheimer's over here, there's another grouping that's called frontotemporal. What is that?
Frontotemporal dementia. And frontotemporal dementia is not Alzheimer's. We do not find plaques and tangles on the slide.
So we don't get the beta amyloid and the tau protein problems like Alzheimer's.
We get tau, but it's a little different, and it affects a very different part of the brain.
Like where?
The frontal lobe, the part that's right behind your forehead. And
so what goes on there in the frontal lobe?
A whole lot. The frontal lobe is important for our mood, our behavior, our judgment and insight, our higher processing.
Whoa, so it's a terribly important part of our activity is the frontal lobe. And we'll talk about what happens when that becomes diseased. Frontotemporal, what's the temporal part?
So the temporal lobes affect also mood, behavior, language. But together, we have a different disease, a disease that with those areas affected can really change a person's personality.
Do they occur later on after the age of Alzheimer's normally, or before normally Alzheimer's? Tell me about what we look for and who can have those.
So frontotemporal dementia is more common than Alzheimer's in those age 65 and younger. It's also the most misdiagnosed.
So how much younger than age 65?
We have some patients that are in their 40s and 50s.
40s and 50s that are having dementia that's not Alzheimer's. What do you see in young people like that? I call that pretty young.
It's very young. And the very first symptoms are insidious, meaning they kind of creep up unknowingly, and it's mostly misdiagnosed as a psychiatric illness. Like bipolar illness, depression, and anxiety.
Whoa. So a lot of that may be bipolar illness, some of it, anxiety, some of it, depression, some of it. Could be a form of dementia, something's going on in the frontotemporal area, is that right?
Yes, and why is that? Well, we think that these areas are so important in our behavior regulation. In the very front part of the brain, there's a part that helps us initiate activities. What does that mean? Get up and go. And our patients universally developed apathy, which is the loss of get up and go.
So that's the frontal part.
Yes.
You just sit there like a blob or what?
Well, yes, and sit there more than is normal. We have patients that will watch hours of television, 10, 15, will sit for or sleep for 20 hours of the day.
Oh, wow.
And so it looks like a depression, but it's not typical. A person that was highly motivated, maybe a businessman, who's suddenly sitting on the couch hours after hours, it kind of sounds like a depression, but it's so distinctly different because that person doesn't seem to be bothered by sitting that long.
So do people around that person that's sleeping, that's got no mental get up and go, that the frontal lobe seems to be changing, who notices that? The spouse, the people at work, who? How do you know?
I think both notice it. Many times the spouse says, is it a midlife crisis? Is it something else? And folks seek psychiatric care. It's not to discourage that because that could still be the diagnosis, but it's a little different. In addition to the apathy, there's something called disinhibition.
So disinhibition, is that abnormal inhibition or what is that?
It's the loss of a social filter.
So you don't have a social filter, so I may just all of a sudden spit while I'm talking, or?
Actually, sure. We find that people will do abnormal burping, belching behaviors. Some people use a lot of expletives or curse words as part of normal language, somebody who would never say such words. Other people will say unfiltered comments. Perhaps they see someone in the waiting room and comment on their dress or appearance out loud to the person. That's not appropriate socially.
So do you say, what's going on with that person? Is that the way you notice, everybody notices something's different? Does the person notice something's different?
The person doesn't have insight. They don't know that they don't know. And in the beginning, a lot of people think that that person is just mean or rude. They don't realize that it's a disease until it progresses into increasingly bizarre or weird behaviors.
Any examples when you say bizarre and weird behaviors? How bad are we talking about? Or that's progressive?
Some of the behaviors that we see are changes in eating behaviors. There is an on but no off button. So
an on but no off.
Yes.
That sounds like me. Just eat all the time.
Well, at a certain point, you start to feel guilty about eating too many things. So in this disease, there is no guilt. It's an impulsive, compulsive behavior where folks will just keep eating and not stop. A great example is I had a family where the wife was affected with FTD, and the husband took away all of the snacks and everything out of their pantry.
It's FTD, that's going to be frontotemporal disease, dementia.
Frontotemporal dementia.
And so the husband starts taking away things.
Because she was eating everything And so finally he caught her one day eating the bag of sugar. That was all that was left. It's a very desperate craving for sweets and carbohydrates.
So do they, would somebody normally say something's going wrong in the brain, she's needs to see a psychiatrist, and really what they're having is frontotemporal disease?
Yes, and I think eventually they make their way to getting a diagnosis, but the goal is to understand that some of these behaviors are a little different than you would see in a typical psychiatric illness.
Are there going to be other patterns that these people have?
There are other things that these people can have in addition.
And that's what we're going to be talking about when we come back. So you can have bizarre changes, aggressive changes, changes that don't go away, that you know are abnormal. It may look like a psychiatric problem. It may be a form of dementia. We're going to be learning more. You'll want to stay tuned. We're talking with Dr. Monica Crane, Clinical Director of the Genesis Neuroscience Clinic in Knoxville, Tennessee. We're talking about dementias. We're talking about there are new things that we're learning about. It's just not the Alzheimer's. And we're talking about frontotemporal dementias, a brand new kind. Starts a little bit earlier. And we can see changes in people's personality and how they're active. So, Monica, this excites me to no end because it just means there's a lot of people out there we can help. Now, how do we make the diagnosis? Is there a type of testing that you do, and what is that type testing?
Well, we start with good old history and physical. And one other caveat, about a fourth of all frontotemporal dementia cases are in those aged 65 to 90. So it can affect all ages. So the first thing is to remember to think it, since it's about 1 in 10 of all primary neurodegenerative dementias.
And I see a lot of people that are over the age of 65, and I've always thought it was like hardening of the arteries up in the brain that's causing the problems. It's more than that.
Yes, and to make a diagnosis, we can also do cognitive testing or neuropsychiatric testing.
So cognitive testing, that's thinking testing?
Absolutely.
So what's that
in
like?
frontotemporal dementia, some of the things that we are looking for are changes in executive function or decision making or verbal fluency, language skills. So we test the language areas of the left frontal as well as the left temporal lobe. And so those are the categories or phonetic fluency parts of the brain. So basically to say you start losing your words in frontotemporal dementia, the memory is relatively okay. So short-term memory is intact. And then the other things that are okay are visual spatial tests.
Now what does that mean, visual spatial?
For instance, we might have someone draw a clock with all the hands and numbers, and in frontotemporal dementia, it's usually okay. In Alzheimer's disease, not so much, and in some of the other dementias that affect visual spatial areas, sometimes it's also abnormal.
So if something's abnormal and you wanted them to draw a clock, what would they be drawing? What would be the abnormality?
We're looking for changes in the hand placement or the number placement. But in FTD, sometimes that's affected, but not because they can't see it properly, because there's a problem with attention. Remember, this is the attention part of the brain. Some of our patients can't focus and pay attention to the task.
So if you were to tell me, put the clock at 4 o'clock, I'd say, sure, and I'd start thinking about, and I just couldn't perform it. I just couldn't put it at 4 o'clock. When you see something like that, when you begin to have cognitive testing, thinking testing, where do you go from there?
So at our clinic, we also recommend doing imaging. So there are different types of images, things like MRIs and CAT scans, which tell us what the brain looks like, that tells us the anatomy of the brain. But
can you see that on an X-ray, an MRI,
yes,
a CAT scan?
And we're looking for focal or specific areas of shrinkage.
Like what?
Like that frontal lobe.
So if that's shrinking and the other person's not shrinking, then you know there's something going on, and you correlate that with the cognitive testing?
Absolutely. You correlate it with the cognitive testing and the history, back to your plain
Wow.
old history and physical. Sometimes there can be movement changes. Sometimes frontotemporal dementia is first thought before it's realized to be a Parkinson's or Parkinson's-like disorder. So it can masquerade as a lot of other things.
How can you take the masquerade of all the things and drop the little diagnosis or know exactly where you are? To me, this is so exciting, and things are happening that we've got a diagnosis in the future and maybe medications in the future. So how do you figure it out?
There are other images that we can do, like a PET scan.
Now, a
PET
PET scan is entirely different. To me, it's the ultimate in finding out what's going on in the brain.
It's one of the ultimates. There are still other tests, but a sugar or FDG PET scan. So there are different types of PET scans. There's one that looks at how your brain uses sugar, and that tells us how your brain works. There are other PET scans that actually mark the abnormal proteins, and that's what's coming down the pipeline, and that's probably going to be one of the best tests, because we can't take a big chunk of brain, and we certainly do not want to do an autopsy. So this is a great way of looking at it.
So you can use this X-ray machine, this PET scan, to find out the different proteins that are causing different problems in different parts of the brain. What are you finding? What parts of the brain, and what are you calling these things?
Well, there are different proteins that we're trying to tag because we think that FTD is very different than these other dementias.
And again, FTD,
frontotemporal dementia. And if you have a hard time remembering frontotemporal dementia, remember, this is the last part of the brain to be developed. So think of how you were once as a teenager. That orbital frontal cortex, the part right above your eyes, guess what? It's the very last part to be developed. That's why you see teenagers making very bad decisions, impulsive, perhaps using bad language too, maybe having other behaviors. So think of that as sort of analogy, not a very good one, but remember, that's the last part to be developed, and it's the first part that's affected in frontotemporal dementia.
So you go back to your teenage years, maybe of bad decisions, bad language, or something begins to happen. The people notice it. What is your research, or what is your involvement with these patients that have a different type of dementia, and you find out where it is and find out the protein? What's that going to allow you to do to help these people?
So right now, we're part of the Forward study.
Forward study.
Yes, and it is a large observational study that's across the country. We're the largest site in the U.S. We're doing it in conjunction with Provision's Center for Biomedical Research.
So you use their scanning expertise?
We're using a lot of their expertise, and they have a lot of experience in clinical trials. But what we're doing is actually trying to figure out which tests best measure frontotemporal dementia and how do you follow it over time. The funny thing is we're still using Alzheimer's paper and pencil tests like the mini mental to follow frontotemporal dementia. But it's kind of like using how you look that day to figure out someone's blood pressure. It's a terrible way to measure frontotemporal dementia. So we're trying to figure out which tests best measure the disease and how you can follow it over time.
So I think what I'm hearing is people that have changes in their ability to function socially, intellectually, executive decisions, social decisions, there may be something going on that's a different type of dementia, that there's hope in the future, and they need to come and have it evaluated. In the Forward study, and Dr. Monica Crane is the one, and I know as busy as you are, I want people to be thinking about this, and I want them to find out if there's another form of dementia. So serious, so important that we do this. Do you think there's going to be changes?
I think there will be a cure. I think that frontotemporal dementia is a bit more specific. It's less age-related. So actually, it might be easier to treat if we can just get a little better at diagnosing it.
And that's what we're after, isn't it? A little bit better so that we can treat, so that we can make the lives of people better, healthier, and not have this problem. Monica Crane, you're just a great teacher. I love having you on the Dr.
Thank
Bob
you
Show.
so much. I really appreciate it.
You're very kind coming. So if you've got changes, don't think it just happens. Be sure that you get it evaluated and get it evaluated properly. Now you're going to want to stay tuned. We're going to be talking about postural hypotension. You stand up and you may get dizzy, lightheaded, and I think we'll talk about the aortic valve rather than the mitral valve. We'll see as time goes on. A lot of information for you. You'll want to stay tuned. I want to thank Dr. Monica Crane. Wonderful discussions on new types of dementia, frontotemporal. Now, questions from you, the viewer, that I think will be important to your health. Question number one. Dr. Bob, every time I stand up, I get lightheaded, I get dizzy. Can you help me? Well, you need to know what your age is, need to know what your blood pressure is, know what your activities are. But it's not an uncommon thing. We call this orthostatic hypotension. Big, long medical words, but essentially what it means is when people stand up, for some reason, their blood pressure falls to the toes and we don't get enough blood to the brain. And when that happens, we get lightheaded, we get dizzy. We may actually fall to the floor, semi-passing out, so that the brain can then get the blood that it needs. What can cause that? Well, dehydration. You've been exercising too much, perspiring too much, you're dehydrated. That's one. Number two, you could have a febrile illness. If somebody gets the common cold, frequently when they stand up, all of a sudden their blood pressure falls down to the toes and they get lightheaded. It can be due to anemia. People don't have enough blood. They stand up, they don't have enough blood to send it through the rest of the body. So all of those things are correctable. If somebody has hardening of the arteries and high blood pressure, there's a little area in the neck called the carotid body. And if that has hardening of the artery, it doesn't adapt when people stand up. So be very careful when you get out of bed, when you stand up from sitting down. If you find you're getting dizzy, just put your hand on something, and usually within a period of 15 to 30 seconds, everything will get well. If you feel like you're continuing to go into space, sit down and be sure that you get adequate help from your physician. You get ready, tell him what your symptoms are, and he'll be able to help you out. Question number two. Dr. Bob, my doctor says I've got aortic stenosis. That's a heart problem. That's a heart valve. We've got the aortic valve, we've got a mitral valve, we've got a pulmonic valve, a tricuspid valve. There's 4 valves. We're going to be talking about the aortic valve. When the big heart pump, the left ventricle, when it pumps blood, it pumps it out the aorta into the rest of the body. That's how the body gets blood. If the heart has a hard time because of narrowing of that aortic opening, aortic stenosis, then there's not enough blood. The heart has to work too hard. The heart gets big because it's trying to use enough strength, and then eventually it'll go into failure. That valve, the symptoms would be shortness of breath, swelling of the feet, not being able to do the things you used to do, can't walk up a hill, can't climb upstairs, can't do anything like that. The doctor will check your aortic valve. There are ways to replace the aortic valve, and it's getting so fascinating. Now they can go through arteries in the groin, come up inside the heart and replace that aortic valve. It's called TAVR, T-A-V-R, total aortic valve replacement. It's amazing. But you have to meet the criteria. You have to understand your shortness of breath is not normal. The doctor has to make the right diagnosis of aortic stenosis. There is a murmur that occurs as the blood goes out. It's usually a rough murmur. If you have aortic stenosis, know that there's good treatment and early treatment so that you can live a long and a healthy life. That's all the time that we have for this show. Let's remember those 5 things that we like to do in the Dr. Bob Show. No, 4 things. Number 1, exercise. Get your tennis shoes, get out, start walking. Walk a fourth of a block, then a half a block, then 10 blocks. Make it so exercise is part of your life. Exercise with a friend. If you want to exercise more, you can be more aggressive. You can jog a little bit. You can get on a treadmill. But exercise will help you tremendously. It will lower your blood pressure. It will make you feel better. You'll get a runner's high. Be sure you're getting 7.5 hours of sleep. The importance of sleep is becoming a stronger and stronger factor. We'll do more shows on that on the Dr. Bob Show, because people that are not sleeping well don't perform well, and it causes other illnesses because it stresses the body when you're not getting enough sleep. Eat properly so that you'll nourish that body. You are what you eat. So eat and be sure that you fuel everything properly. And so we eat more fruits and more vegetables, more antioxidants and less fried fatty foods. And most of all, what is it we like in the Dr. Bob Show? It's that laughter in your life. Remember, when you laugh a lot, your immune system works better. The people around you perform better. They'll be happier, you'll be happier, and when you're happier, you will be healthier.